Good afternoon.
If you want to use that.
Thank you very much. I hope you'll bear with me while I figure this out. My name is Denise Lopez-Majano. I thank you all for being here and for watching. I am Matthew and Alexander's 24/7 caregiver, advocate, mom. Matthew's 21, Alexander's nearly 23. Both are severely disabled by this illness. It's important to have a sense of my sons before they became ill, hence the slide. I'm going to focus today on Matthew, who got sick first, because I only have 20 minutes to share some of the experiences of these past 9 years. I'm not belittling Alexander or the severity of his illness. If I had time, I would gladly share those experiences with you. Matthew had originally agreed to take part today, but he's been too sick to be able to do so. I appreciate the opportunity to speak here today, but in preparing my comments, I put off digging out the medical records from Matthew's illness onset in 2005. When I started reading them, they triggered awful memories. That whole time was fraught with fear, with confusion, and much, much more. Now let's see. You asked what took us to the healthcare provider. In January of 2005, right after his 12th birthday, Matthew developed a sinus infection. Within 3 days, he had pneumonia, then bronchitis. After that, we had to go back to treating the sinus infection. Throughout the next 11 months, Matthew struggled with sinus infections. Also throughout that time, these are some of the symptoms that we dealt with. One of the things that was truly horrible was witnessing his sudden inability to access his brain. When speaking, he would mix up syllables or use one word but mean another. Matthew had taught himself to multiply before kindergarten. So at age 12, his abrupt inability to do mental math was frankly terrifying and spoke volumes to me. He suddenly couldn't do mental math that at age 5 had been effortless for him. I knew something was horribly wrong. Any attempt at physical or cognitive activity made his symptoms worse. And sometimes after orthostatic intolerance episodes, he was so wiped out, I had to feed him and dress him so that we could make it to yet another medical appointment. Despite how sick he was, and despite all the trips to the doctor to try to figure out what was wrong, I knew Matthew needed to stay connected with friends. One of the things both of my sons excelled at was competitive swimming. While Alexander continued to compete, Matthew couldn't bear to watch practices or cheer his brother on at swim meets. I tried over and over to get him to go so he'd stay connected and have a sense of normalcy. But he couldn't. For him, it was a horrible, painful reminder of what he could not do. And it was wrenching for him to watch his teammates cut corners on drills. They didn't know how lucky they were to be able to practice, and he would have given anything to be healthy enough to do so. Finally, in July of 2005, I told the primary care physician that I didn't want to believe in it, but what fit Matthew's symptoms best was, and he interrupted me and said, chronic fatigue syndrome. The best Matthew can manage while managing to keep his symptoms bearable, in other words, his baseline, is some of what's on this slide, most of what's on this slide. And perhaps he can choose a drink to go with his meal, or clear his place at the table. He can't use the stairs if I'm not home. He has so many syncopal episodes, and his older brother's so sick that he wouldn't be able to help him if Matthew got hurt on the stairs. So we accommodate that. Matthew only changes floors if I'm at home. He can only leave home maybe once or twice a week to go to medically related appointments. That's about it. That's about all he leaves home. Anywhere he goes, I must drive. At age 21, he has not learned to do so. In addition to the energy and decision-making required to drive, slowed reaction times and syncopal episodes make it unsafe for him to do so. Matthew is an engaged, curious, lively, intelligent young person whose life has been stripped down to this. Baseline is the most he can hope to get back to. My son's illness involves many symptoms, but is characterized by significant cognitive impairment and post-exertional malaise, which some know as post-exertional collapse, resulting in crashes. By crash, I mean the event brought on by a small amount of activity that results in an exacerbation of symptoms, usually bringing on additional symptoms as well. I'd like to give you an example. I felt it was important to attend the 2013 FDA meeting, but it meant that Alexander and Matthew had to come with me, as there was no one who could stay with them during that time. To try to prepare, Matthew went on full preemptive rest. Among other things, this meant not helping with the dishwasher, not clearing his place at the table, no appointments, and certainly no social activities. At the meeting, he had to stay in the hotel room because lights, conversations, smells, visual stimulus would be too much sensory overload. Despite these measures, Matthew started crashing on the second day. He didn't have to tell me. I knew when I saw him that he was crashing. He was glazed and pasty looking. He was monosyllabic. He couldn't even think about eating. He didn't have the energy for it. He moved as if he was struggling through molasses. So even though he had tried to prepare and budget for it, and even though he didn't attend the meeting, he crashed. And this crash was really bad. During the first week, he had the incessant feeling that breathing was not automatic and that he had to think about breathing in order to breathe. He felt his brain was barely functioning. Think about it. Please, think about what it must feel like to have to think about breathing in order to breathe. During crashes, the cognitive impairment is even worse. Matthew can't make decisions, even something as simple as what to drink. He may be able to say yes or no to an option, but if his answer is no, he can't come up with a substitute. Matthew has even greater difficulty communicating, more trouble finding words, and difficulty following more than a few sentences. He frequently zones out mid-sentence, mid-bite, mid-word. It's as though his brain gets stuck on hold. Matthew's eyes are even more bothered by light, so the blinds must be closed. To try to minimize the impact of sounds, the house must be quieter than usual. His sense of smell is even more acute, so cleaning products must be avoided, and cooking smells must be very bland. It's almost impossible to predict what his digestive system will be able to tolerate. Leaving the house during a crash isn't an option because doing so exacerbates all symptoms, triggers additional ones, and prolongs the crash. The only way to cope is to shut everything down. By comparison to many other patients, our journey to diagnosis was relatively easy. But we have encountered multiple obstacles in dealing with the diagnosis itself. The pediatric ID doctor who confirmed Matthew's diagnosis said, "Take him home, take care of him. Some of these kids get better, some don't." He prescribed exercise, insisting that Matthew also had to attend regular school full-time, but ignored the fact that Matthew was too sick to attend school even part-time. He provided no guidance about care, about post-exertional malaise, or how to try to avoid it, gave no information on cognitive impairment, and provided no insight into how Matthew might be one of the ones who gets better. This left us feeling that if Matthew didn't get better, the blame lay with us. In 2005, Matthew was sleeping at least 12 hours a night, waking unrefreshed, familiar to most patients. The primary care nurse berated me for letting him do so. She repeatedly pushed me to send Matthew back to school, despite my explanations that he was too sick to attend school. She ignored my explanations about the range of severity for this illness. She was not interested. She insinuated that I shouldn't believe Matthew, that I was a bad parent who was making excuses for his behavior. The school nurse repeatedly demanded that the primary care physician release Matthew's medical records to the school. She also insisted that Matthew had to see the primary care physician every week to get a new note verifying that he was too sick to attend school. Despite repeated explanations, she didn't understand that going to the primary care every week set Matthew back rather than giving him a chance at recovery. In what other chronic illness would a school nurse insist on these things? But it happens with this illness, and it speaks to the disbelief of the severity of this illness. Many healthcare providers stress the need for exercise and refuse to pay any attention to any information I gave them on it. Interestingly, it was only after diagnosis that the sudden admonishments about exercise began. Before that, even on a first meeting, without knowing that he was an athlete, healthcare providers never asked how physically active Matthew was and never mentioned exercise, because I looked at the records from before 2005 also. What did these sudden admonishments tell me? At best, they indicate that healthcare providers have no concept of exercise and this illness, but it also told me that healthcare providers don't know what else to do for patients, that they don't believe Matthew, and that they don't believe me. And all of this ignores who my sons are. No one educated us about post-exertional malaise or about how exercise is different with this illness, and certainly no one explained that cognitive symptoms are among the most devastating and most frequent symptoms of this illness. In 9 years, only one healthcare provider has given us any guidance on any of this, and that's the specialist my sons are fortunate enough to see. So more than 9 years into this horrid illness, Matthew's symptoms include all of those from 2005, and some additional symptoms are listed on this slide. He's even more impaired and disabled. On several occasions, though, he has told me that if he could fix only one thing, it would be to have access to his brain without the repercussions of post-exertional malaise. Every activity has to be carefully planned, based around the energy demands of every other activity. Things like taking a shower or physically draining have to be carefully planned for and can only be done a couple of times a week. There is no more spontaneity in our lives. Spontaneity means you have enough energy to add in an unplanned activity. Long gone are the days that beautiful weather like today would take us out to the park or lure us outside for a walk. As you can see, despite getting the best possible care, Matthew has not had much change in his functional status. Which brings me to what healthcare providers must know. Everything. But if I had to choose one thing, it would be recognition of the debilitating impact of post-exertional malaise and cognitive impairment. Healthcare providers need to understand the seriousness of this illness and the endless adaptations patients must make as a result. Patients' lives and their families' lives are destroyed by this illness. The paths they had chosen, or in my son's case, had hoped to follow, have been obliterated. And the new reality is a tightly circumscribed life because minimal cognitive or physical exertion cause such extensive repercussions. If healthcare providers had helped us understand post-exertional collapse and cognitive impairment, we might not have altered Matthew's physical state, but our lives would have been somewhat more tolerable. Instead, they said, "Good luck," and sent us on our way. And I was berated for believing Matthew, and Matthew was told to exercise but given no guidance on it. We're traumatized by the obstacles between us and diagnosis, traumatized by the pervasive stigma, traumatized by healthcare providers' overwhelming lack of knowledge about this illness, traumatized by the obstacles between us and appropriate care. So how did we get this far? My father was a physician. When he was alive, he was sometimes able to help with resources and contacts. We have decent health insurance coverage and some degree of financial resources to be able to pursue options. We're lucky enough to live in an area where I can often find what we need. And I have been available nonstop to try to find answers and provide 24/7 care. I'm quite accustomed to doing research. For example, in 2005, I figured out that Matthew had orthostatic intolerance, and I asked the primary care physician if he could try a beta blocker. Later, I called hospital after hospital to arrange for a simultaneous tilt table test and EEG to rule out seizures. At that time, no facility near us had done a simultaneous tilt and EEG, and most places wouldn't even consider doing it because Matthew was under 18. So this required many, many calls. I found someone locally to do some neuropsych testing based on Dr. Lang's work. The findings indicated that Matthew's IQ results were artificially low because of impaired working memory, slowed processing speed, etc. Matthew's ability to function at his intellectual level is significantly impaired by this illness. The intelligence is still there, and he knows it. Making use of it is almost impossible. For over 9 years, I have been doing everything I can to help my sons. I'm sad to say I haven't been able to help Matthew get any better. We got this far because of resources, but what about those who don't have resources? For them, it's even worse. In addition to our examples, there are countless incidents of harm suffered by patients because healthcare providers don't know about the impact of post-exertional collapse and cognitive impairments. I am not here for pity. I am not here for attention. I am here because you have the opportunity to help my family and all of the patients and all of the families who aren't here today. Healthcare providers can help patients begin to adjust to this hellish existence. One way they can do so is by providing proper advice on avoiding post-exertional malaise and by understanding and acknowledging that cognitive impairments are frightening, frustrating, and greatly impact patients' lives. If healthcare providers can help patients last until they can get to a specialist for more help, it would be a step in the right direction. The report you produce must ensure that at least this step happens. Thank you.
Thank you very much. I assume, are you reading from a written script, it looked like?
Notes.
Notes? Okay. I was hoping that you could share them with the committee. Thank you very much. Our next speaker is Robert Miller.